for her 5 minutes.
Thank you, Mr. Chair, and I thank all the witnesses who are here. Dr. Walensky, you and I have had the opportunity and the pleasure, if you will, to receive testimony before and ask questions. I'm a physician. I'm also a former director of the Iowa Department of Public Health. And when it comes to trust in our agencies, if you've lost me, that means there is a lot that has to be answered for and oversight that has to be taken care of. I vaccinated individuals, all 24 of my counties in my district. I was vaccinated, but even now, there still persists this non-recognition of infection-acquired immunity, of herd immunity, of immunity that exists. And the purpose of a vaccine is to do what? It is to confer immunity. So the failures of the CDC and the FDA, and I won't get into the NIH, were both administrations. There was the first failure to not to develop testing in an appropriate, adequate fashion for COVID-19, despite the fact that there was already a test with high specificity and sensitivity from the University of Iowa. The failure of the CDC to use real-world evidence and data when studies from Israel or other countries showed that viral transmission still existed despite vaccination. The failure of the CDC and other public health organizations to acknowledge infection-acquired immunity despite data from other countries, and that there were waning antibodies within 1 month after vaccine. The failure to acknowledge infection-acquired immunity or natural immunity and mandate vaccines to those who already have immunity. And I put forth a bill to mandate that all insurance companies, public and private, cover for antibody testing and T-cell antibody testing to get to this point. The failure of the CDC to acknowledge myocarditis and pericarditis in young people and still advocate for vaccines in young men despite that risk, which, as we talked about finally last year, that there's a risk-benefit that has to be considered, but was not considered in these mandates. Menstrual irregularities in young women. I think that when you're trying to message to the public, and I can tell you as a public health director, what I conveyed to my staff was that our credibility was the most important thing that we had in public health. And so when we can't acknowledge what are common concepts and what my local public health individuals and officers and physicians and nurses were acknowledging back at home, but we're not receiving through the CDC, has created a lack of trust in extremely important institutions. The failure of the FDA to utilize their own advisory boards when approving vaccines, especially in certain age groups, and rushing approval in these age groups, and then their slowness to advance any therapeutics. And what evidence, can you tell me, the evidence-based research that shows 6-foot distancing is appropriate? It's demoralizing and it is depressing that agencies that were once held in such esteem cannot translate and transfer research and evidence and respond to real-world evidence when they come up with strategies and policies. It's not just a messaging problem. It was a problem of bias within the agencies. So I was the sole member of Congress to advocate on Congress during the COVID-19 markups and hearings for increased funding for public health and local public health grants. So Dr. Walensky, currently states and localities must apply for a CDC grant funding for chronic diseases vis-a-vis different applications, submissions, and portals for each specific program and grant. Heart disease and stroke, diabetes, and 14 cancer programs, for example, all require this. These applications are burdensome. They require vast amounts of time and resources, and often states and localities must hire specific grant coordinators to handle the process. It appears that a much simpler approach, such as the grants to local public health, would be for states to work through a block grant process, submitting one application to CDC for funding for specific chronic diseases that will meet the needs of their specific state. Many of these entities already are operating on slim margins, which is also why, quite honestly, I found it appalling that less than 0.5% of the American Rescue Plan dollars in 2021, the height of the pandemic, went to fund state and local public health workers who are on the front lines of fighting COVID-19, all with tremendously innovative policy and procedures to combat the disease. Updating the grant structures to be more streamlined could reduce administrative burden for both states and the internal CDC review process. Plus, if we require appropriate reporting, we can ensure each state is putting the money to good use, something that should be a paramount focus given the alarming rates of fraud and abuse within the COVID-related dollars. Has the CDC considered this structure?
Yes, thank you, Dr. Miller-Meeks, and thank you for advocating for local public health, which I think is a critically important part of one of their lessons learned as part of COVID-19. Results-based partnerships is one of the key things that we learned in our CDC review and CDC moving forward. And part of our organizational structure has actually streamlined where our local public health departments come. I can tell you as part of the $3.2 billion that went out for workforce grants, it didn't just go to states, it went to states and local jurisdictions for exactly the reasons that you know.
Yeah, I think
Generally
currently our
yields
local public health has the trust that the CDC is lacking.
Gentlelady
Thank you.
yields
I yield
back. Recognize the gentleman from Maryland, Mr. Sarbanes.
Thank you very much, Mr. Chairman. Thanks to all of you. I know this is part of your job, coming up here and testifying, but I still always feel guilty when you've spent 3 hours here away from your primary responsibility. So thank you for your testimony. Dr. Walensky, I was going to talk with you a little bit more about the whole data picture. I know you've answered a ton of questions already today about that, but I want to understand a little bit better where the line is in terms of being able to build a sophisticated and as accurate as it can be model or platform for both tracking and forecasting infectious disease, whether it's a COVID outbreak or anything else. Where the line is between what you can collect through the voluntary cooperation of public health officials, private labs, et cetera, and what you can't really do without the authority to force that. As I ask you that question, I'm thinking about the dashboard that Hopkins built, which became a go-to place for many of us and billions of impressions, people all over the world, using that to kind of see the heat map when it came to COVID spread across a number of different categories and measures, which my sense is was largely being done by rolling up publicly available data in many places, qualifying it where it needed to be qualified or disclaimed, so that people consuming it understood, how much weight to give it on a particular day, but became a fairly reliable go-to picture of what was happening. But to the extent you've signaled that you need more authority to build the kind of robust data platform and collection, the vehicle that you'd like to see, describe maybe in a little more detail, maybe an example or something of where that line is and why working with the toolkit you have right now just isn't sufficient.
Great, thank you for that question. So I bucket it into two different areas. One is our data modernization efforts. That is building the highways. Can your jurisdiction, your district, send data to CDC in the similar way that the one next to you can send data to the CDC, and then CDC can rapidly receive it and give it back to you so you can see what's happening in the districts around you? That's a data modernization issue. We are working on that. It is because we lacked that modernization, those data highways, that we only had 187 healthcare facilities in the country that could provide us with data electronically on COVID. We're now up to 22,000. Those resources are being put to good use, and we have numerous examples of how we've been able to use those highways for MPOX reporting and many other things. Once those highways are built, and we will need more resources to build robust highways across this country, we have another challenge, and that is, do the cars drive on the highways? Right now, we only receive those data that are voluntarily reported in the absence of a public health emergency. So you're exactly correct. The Hopkins website does data scraping, web scraping, so that they can see what's publicly available. We at CDC would like the gold standard of what's happening at the states because it's reported from the states, but we only get that voluntarily. Even today, I can't tell you how many people have been vaccinated in the hospital. We don't have data systems that can do that. We don't have authority to collect it, and it's not voluntarily reported. So after this public health emergency is taken down, we are currently, again, working through data use agreements. We will lose data on testing, and we will lose some data on immunizations. infections. We're working through data use agreements, but that's just one infection. That's just one infectious disease. And so that leaves us really vulnerable if we don't have reporting coming to the CDC on what's happening in influenza, and what's happening in RSV, and what's happening on many of these other.
Let me ask you, on the hospital front, I mean, obviously HHS and other agencies have leverage with respect to hospitals based on all kinds of other engagements. Are you saying that leverage can't be used to pull data in from those places? You have to have a separate authority to do that?
Well, first of all, we would have to rely on partnerships with other agencies, and that's exactly what we did through the public health emergency. And we are receiving some of those data through the public health emergency. But we don't have that authority independent of relying on those partnerships, and it's not as robust. Not necessarily the data that are collected for purposes of CMS may or may not be all of the data that we need for purposes of tracking a new outbreak.
Okay, thank you. I yield back.
Gentleman yields back. Now recognize the gentlelady of Florida, Ms. Kamick.
Thank you, Mr. Chairman, and thank you to all our witnesses for appearing before us today. First, is it Dr. Tabak or Tabak?
It's Tabak.
Tabak?
Yes.
I appreciate that. I've heard it multiple ways said today. I wanted to be.
I answer to hey you. It's okay.
Okay, I appreciate that. All right, Dr. Tabak, you've been with NIH since 2000. Do you believe that Stanford Medical School, Oxford, and Harvard hire, quote, fringe medical professors?
It depends on the individual professor.
Okay. Well, the reason that I ask is because on October 8th of 2020, you were CC'd on an email from the then head of NIH, Dr. Francis Collins, to Dr. Anthony Fauci. Now, I'm going to refresh your memory on the contents of this email. It says, "Hi, Tony and Cliff. This proposal, citing the Great Barrington Declaration, from the 3 fringe epidemiologists who met with the secretary seemed to be getting a lot of attention, and even a co-signature from Nobel Prize winner Mike Levitt at Stanford. There needs to be a quick and devastating published takedown of its premises. I don't see anything like that online yet. Is it underway? Signed, Francis." Again, you were CC'd on this email. Yes or no, Dr. Tabak, did you communicate with Dr. Collins with you about these doctors or the Great Barrington Declaration other than when emailing Dr. Fauci?
I have no recollection of speaking to him about that.
Yes or no? Are you aware of other instances where either Dr. Collins or Dr. Fauci plan to have the media publish articles to discredit other scientists or doctors during the COVID-19 pandemic?
I'm not aware of any such instance.
Of course. Now, as Deputy Ethics Counselor at NIH, aren't there ethical concerns about using the U.S. government to silence scientific speech, particularly peer-reviewed speech? When the stakes are so high, right, as they were during the height of COVID-19, shutting down economies, keeping kids in schools, increased rates of mental illness, addiction, suicide, et cetera. And now, of course, we know that the collusion between Twitter and the Biden administration has come to light. Does that not concern you?
I'm unaware of any collusion. I know there's ongoing litigation.
You know what? That's good.
So
I'm glad. I'm going to
comment
enlighten
about
you
it.
then. So just a few months after that email, this email that you were CC'd on between Dr. Francis Collins and Dr. Fauci, you have records of this, and I'm sure there are others. Just a few months after that, Twitter was directed by the Biden administration to deplatform multiple scientific accounts, doctors, Nobel Prize winners. They went so far as on March 14th, 2021, in internal communications between top Twitter executives and the Biden administration to say, "We are very angry. The Biden administration needs a push to deplatform these multiple accounts." These deplatforming of accounts were, of course, related to the Great Barrington Declaration. And they said, according to the Biden administration, to Twitter, that not enough had been done to silence these doctors. Dr. Tabak, did you provide Dr. Collins with any ethical counsel or advice on this matter?
this is a subject of ongoing litigation, and I can't comment on anything related to the social platform.
Who else at NIH did you talk to about the Great Barrington Declaration and its authors?
I don't recall speaking to anybody about that at NIH, quite frankly.
Okay. I know I'm running low on time, but I will say this. Contrary to some of the comments that have been made here today, and we're not going to get to the bottom of this in 53 seconds, but contrary to the comments of some of my colleagues today, actually just now, apologizing to you all for before appearing before this committee, saying that we're taking you away from your primary responsibility. You have a responsibility to appear before this committee, just as we have a constitutional responsibility for oversight. That is our duty to the American people. If I were you, I would clear your schedule. This will come to light. I appreciate you all being here today. Thank you.
Gentlelady yields back. Now recognize the gentlelady from California, Ms. Barragán.
Thank you, Mr. Chair. I want to remind the public, because it was there was a comment made that there had been no hearings on COVID, but we did have a hearing in June of 2020 on the response to the COVID-19 disaster. And a lot of that, as I remember, was a disaster under the prior administration of the response, the lack of response, the lack of acknowledging the seriousness. And I remember even claims about you can inject bleach to deal with it. I mean, the misinformation and the disinformation is a huge concern because clearly we know it has public health impacts. And it's really unfortunate when science is not taken seriously and when the misinformation and the disinformation continues. I want to thank you for the work that you do day in and day out. I know that your primary concern is of Americans and making sure that we are doing all we can to fight infectious diseases and non-infectious diseases. Dr. Walensky, I want to thank you for your willingness to not just do the work, but to go across this country and travel into communities, to meet constituents, to meet public health officials. Thank you for coming to my own district in Watts last year to talk about the importance of awareness and vaccines, something that I believe saved millions and millions of lives, and that nobody really should have doubted the numbers that we saw happen. So let me start, Dr. Walensky, with you with a non-COVID question, really. Heart disease, diabetes, cancer, and Alzheimer's are some of the most common causes of illness, disability, and death affecting a growing number of Americans. Many chronic diseases disproportionately impact people of color, people in low-income neighborhoods, and others whose life conditions place them at increased risk for poor health, especially during infectious disease outbreaks. Can you talk a little bit about and discuss what the CDC is doing in this space and the important role the CDC plays in addressing non-infectious diseases?
Yeah, thank you so much for that. I think it's critically important to recognize our role in our infectious diseases for sure, and in non-infectious diseases as well. So as you know, heart disease, mental health, opioids, diabetes, cancer, in the prevention and outreach for all of those non-infectious diseases. What I think is lost is in the conversation, and also critically important, is the intersection of the two. So those people who had the most severe outcomes from COVID-19 and continue to are those who have those chronic medical conditions. It is because we have a partnership in cardiovascular disease, we have that work ongoing, that we can have subject matter experts in both of those coming together when we have a public health threat like COVID-19. Similarly with Zika, devastating infectious disease for pregnant moms, maternal mortality, anencephaly in children. It is because during the Zika outbreak that we had our infectious experts in infectious disease working alongside our birth defects experts that we could rally a response so quickly. And then maybe the third very vivid example that I will give is in the opioid challenges that we're having now, over 100,000 deaths per year. But we have also those who have suffered from non-fatal overdoses related to injection drug use. The coincidence of opioid use and HIV and hepatitis C and endocarditis, where I've spent much of my career, is really why it is so critical that we in public health are addressing both of those together. Thank you.
Great, thank you. Dr. Tabak, I want to quickly get you in. Trial diversity is essential to develop effective and safe vaccines for all populations, but this is not always the case in the development of new vaccine treatment. While developing multiple COVID-19 vaccine candidates in record time, the NIH did include a diverse pool of trial participants. Dr. Tabak, how was the NIH able to achieve this, and why is it important as we think about future pandemic preparedness?
We were able to do this first by encouraging the vaccine manufacturers to ensure that they included a diverse population. But we also had to gain the trust of the individuals, particularly from marginalized communities. And we did that by taking advantage of equities within those communities, trusted persons, pastors, pharmacists, and so forth within the community, who would allow us to share information about COVID, information about vaccines and therapeutics, and of course, the reason why it's important for all people to participate in clinical research.
Great. Thank you so much. My time is